Welcome to the fourth episode of the AI Oncology Revolution. I'm Dr. Arturo Loaiza-Bonilla, and I'm here today with Connor Yost, who is a resident at Creighton University and an aspiring Hematology and Oncology fellow in the application year. Would you be able to tell us more about yourself?
Yeah, so I'm an internal medicine resident. I'm applying to hematology oncology this July. Um, my background has been really shaped by so many things. I before med school, I worked in the private sector within business, and I've had huge business interests within engineering and some informatics background. And so as I entered medical school and residency, I've really shaped my interests within a lot of the large language models and machine learning and the AI surge that's happened. And so within that, I've done a ton of research within the education space, within the business space, with ambient learning and ambient listening, and also within decision making and being able to research how language models are really affecting that. To me, oncology is at the forefront of a lot of the technology that's being pushed, whether it's helping students understand how to deal with the hard conversations in oncology or helping, people be able to answer questions more effectively or simply just being able to be more present for our patients. My expertise and my research within this has really helped shape my path towards oncology.
That's awesome. I always welcome the chance to talk to those unique profiles that combine not only their interest in clinical medicine but also want to imbue some AI technology and innovation. So it's very nice to talk to you about this. So what is the topic of today's discussion? So in AI Oncology Revolution, we always want to diversify and kind of find these, niches and opportunities to see what technologies are emerging and what people are doing, and to optimize their daily practices and the lives of others, right? We all clinicians will want to work together to make our lives easier and also for our patients. So today we're going to be discussing something very unique that is called Nurse Althea, like the nurse, and her name is Althea, and is an AI-powered chatbot. That it was built, by residents, for residents, and beyond. And I would just love to hear more about what is Nurse Althea, and tell me more about that.
Yeah, so when I was a fourth year medical student, we were doing this residency readiness program. And during it, I was selected to be part of the research committee within trying to improve the program. And so I had this thought that we were having nurses call students, and I said, hey, when I've worked a night shift, usually it's not a call, right? It's a message. That's where we've moved. And so I wanted to figure out how I could simulate medical students and even interns being in the hospital learning how to cover overnight pages. So I built the initial version of Nurse Althea, which was just a chat bot that we would send messages to students and they would just chat with the nurse back and forth, where we would message the nurse and kind of have, practice conversations, where they were able to ask questions and research and learn about, the patients in a safe environment where they could practice. So this developed, I applied for a grant, and I got one for a residency boot camp grant. And then the project continued to develop, and I applied for the American Medical Association education grant, and I participated in the contest within 30 medical schools across the country, and I actually won to develop my tool. And so since then, we've been developing a tool that is all encompassing to simulate overnight pages for medical students and for interns. We've tested it out at 5 different medical schools and programs already this year. And the simulation really follows this pattern. The student gets a message, they then log on and they can chat with the nurse. They can go to an EMR and they can place orders. They can review notes and they can check vitals and make decisions. And then when they're finished with the case, they then write a progress note and then get feedback on their communication and their medical decision making. Now, why is this important? We're in the process of publishing some papers on this specific field, which is overnight communication and where a lot of the errors happen. And the issue comes to the fact that in medical school, you don't learn how to communicate with other staff. You see it, but you don't practice the type of communication that is medical communication. So these students will participate between 6 p.m. and 2 a.m., and it simulates this high yield, high intensity type of environment. One of the types of situations would be patients in pain, right? They've got, multiple metastatic cancer. I need some pain meds. And the med student has to review the notes, see what they've been given, ask questions about where the pain is, and try not to miss something that could potentially cause harm to the patient.
No, that makes sense, and very relevant because as many of us, and of course, been decades now since I did that, training. We all used to simulation with a step three and whatnot, and we have our step two CS, which is a clinical skill set where we talk to patients or simulated patients. But even then, it's hard to really extrapolate it to real world, right? When you're actually in clinic or in the hospital in the middle of the night, getting a pager as an intern, and you get a little bit of exposure that as a sub-I, but not everyone can do a sub-I in their subspecialty. And I remember myself, international medical graduates, they could still comprise a significant proportion of the residents. And there are certain terms or things that we would probably benefit from using these tools. I just remember many, many years ago, just an anecdote that a nurse called me and asked me if I was able to put an order for a pick line. And I was like, what is that? I'm like, without because that's a very unique way of describing a pick line. We all know what it is now, but peripherally inserted, central catheter, right? It's straightforward if we talk about it. But I was like, you say pick line like PIG? What is this talk about? And it was just like just thinking it was very simple. But how helpful would it be for me at the time, 20 years ago, to really have something like this that was able to really explain to me things that I was not exposed to before, and
Yeah.
that they assume that you're supposed to learn. So I think this is great. So what is the end game for you on this chatbot and beyond?
Yeah, so I think within the space of medical education, I'm not seeking any sort of business model or trying to find, a way to make money. What was interesting about the cost, and this is important, is that not only was I able to build this tool mostly by myself, and I'm not the best coder in the world, but the technology has advanced so fast that I was only able to use a little bit of it for another developer to help me with the harder parts. But the total cost to run the simulation for over 450 med students and somewhere around 3,500 total cases was around $800. And that's significant. That's not that much of amount of money for all those students to run these overnight pages. So to me, the point here is that patient safety starts with safe medical decision making and safe communication. And we can spend all the time we want during the day supervising these interns, but at night, that's where the mistakes happen. And to me, the point of this tool is to try to make a significant dent in the medical education system and in the patient safety factors that come with it. So our steps right now is we're trying to find a good home, but we're expanding still with our grant money to some more medical schools within the next year, and we're going to be publishing a lot of our data. The sneak peek of the data that's the most interesting here is we created our scoring system based off of what residents and attendings would do in these situations, how many questions they would ask, the type of order of steps they would do, how they talk to the nurses. And then we extrapolated that back and created algorithms to measure these students. And the medical decision-making scores of the students was very close to a second-year resident, right?
Mhm.
They did pretty good, right? We should be proud of our medical education system for teaching these thought processes. The issue, though, wasn't in the medical decision making, it was in the communication. The scores were significantly lower for communication when compared to a typical resident overnight. And that's because we don't get this practice. And a lot of the medical decision-making errors were because they didn't know how to ask questions to the nurse, or they took too long in the case to get to the answer. And they weren't hard questions, right? But big mistakes could happen. And that's what
Yeah.
we're trying to combat.
Yeah, no, I agree. And also, as you know, folks starting that medical training, it gets intimidating because, this is a very experienced nurse that they just want quick decision making right away. And they just anticipate that we're going to know the answers immediately. So I think this is helpful to have that framework, and also kind of goes two ways, right? Maybe we can also optimize some of the communication that happens in the floors by the way that, nursing staff and others ask us questions. So this could be a good translator for it. So no, I appreciate your insights in. Looking forward to see more about Nurse Althea and many other kind of nurses. Maybe they have different names based on the use type and location. Um, by the way, where's the name from?
So, Althea is the Greek term for within medicine for healing. And so, when we were trying to come up with, what do we want to call this, right? We were trying to represent the fact that nurses are a representation of healing, and that, that they're our co-workers. They're not under us, they're not over us. They work with us. And we wanted to symbolize just how powerful the word nurse really is with this. And so we tried to give her a name or a name that reflects the impact that they do have on their patients.
I love it, and I love to put names to products. So, and particularly like Greek names and stuff. So amazing. All right. So what are the, as we go forward in terms of opportunities for this, do you think that maybe we should incorporate like guidelines or something specific to this to make it more grounded? Because we know there's a number of efforts happening now when we have chatbots or LLMs or whatnot, that when they have a connectivity through RAG or a knowledge graph that links to, they tend to have better answers. And that is also a segue to another question I have for you in terms of things that you presented at ASCO. But let's just talk about first Nurse Althea, and then we kind of move forward to the next one.
Yeah. So the point of the chat bot, and we do give it a knowledge base of we want it to do this, this, and this, are some we've played into the strengths and the weaknesses of language models for this. And this isn't to be a rag on anyone. This is just to simply be the reality of medicine. I don't mind when our chatbots hallucinate. I don't, because you could call sometimes some of the messages I get by nurses hallucinations, right? Um, we're focused on the fact that it's the workflow and the cases that students go through, and trying to teach things that are relevant. Just because a nurse tells you something doesn't necessarily mean it's always true. And so the cases where we've had students complain and go, the nurse told me this, but the note said this. I said, well, how do you know that's not part of the curriculum? And even if the prompt wasn't followed fully, it's on doctors always to make sure things are correct. Now, where are we headed with this? I am trying to advance the tool to make it more usable so that other schools can create their own cases without having to have my knowledge of how to set up the programs and everything. And then we are trying to advance the feedback tool. Those are the two things that we're really focused on over the next year. The feedback for this is important, almost as important as the practice itself. And I have a lot of issues with large language models giving feedback. So the model or the roadmap that I'm going on feedback evaluation is the hardest part that I'm going through right now. And I've criticized a lot of other medical schools and people within the AMA on their ideas of using these tools for evaluations because of the consequences of these models.
Makes sense. So And that opens a segue. So, and for full disclosure to the audience, Connor, Dr. Yost, from prior work that we're looking into line language models and beyond, but he's going leaps and bounds, working his own way to build them new frameworks, looking at LLMs and how they're helpful in making decision support, particularly in oncology. And that's so relevant because recently we have this big controversial paper from NYU, kind of like testing the frontier models, ChatGPT and Gemini and Claude and even Quen, which is the Chinese open source model, and compare it to more specialized models like Open Evidence and up-to-date AI. And they were trying to, make a difference. And the interesting was that, there was really no major difference by asking a question to the LLM as it was able to answer specific questions based on some benchmarks there. And that connects to something that we presented at the ASCO AI community of practice, and I welcome everyone to join us for that because it's a very good forum. But part of that was the work that Connor had done by analyzing precisely that question on the oncology use case. So I would love you to tell us more about that work and some of the things that came up from that collaboration and assessment.
I think that we are going to see a lot of different research come out over the next couple of years within language models that to the common eye is going to disagree with each other. And that's really hard because, as someone who reviews for digital medicine for Nature and for other journals, um, the questions matter that you're trying to ask. So let's kind of break down a couple different things within this, right? And this is relevant for both my tool and for anyone's tool. Generalized language models are really good at being trained on the most common answers to things, right? Because their database, their corpus of knowledge is everything that has ever been. And their goal is to sound right. So when we ask common questions, common answers occur. This other side of the coin is what a lot of companies are trying to do, which is how do I take a model and make it more relevant to the questions that are not common? And how do I make it relevant to unorthodox type of questions or scenarios that are more complex? And what we know about language models is this. There is a formula of time and size of and complexity of question, as well as prompt, right? So all of these things have an effect on the hallucinations and the accuracy of the output. And as the models get better, the amount of time they need to search comes down, and the amount of data they're able to search through goes up. So we're seeing increase in their capabilities, right? So if I am trying to ask a general quick question, I find that normal language models are great at answering those, and I don't need some specialized model that's trained on data. They're fast and it's not complex, and when they're wrong, I can usually identify quickly that it's wrong. When I get into what do I do about this patient? Now we start asking things that might be things I don't know. And it becomes not just about the quality of the answer, but the trust in the sources it pulls from. And so, what a lot of models like Open Evidence and other companies are doing is they're trying to tie the vector in which it pulls this from, right? We regard this to as retrieval augmented generation to literature. But how does it prioritize that literature? How does it rank which literature it should pull from? And so you ask a generalized model, it's going to give you the most common question that's recited most commonly and most frequently. But when you ask it a complex question that requires more nuance, you're going to have this model search the literature Does it search the literature that's the most cited? Does it search the literature that has the highest amount of patient data? Does it search the literature that's the most recent? There are so many compounding factors here that it has to go through, and it doesn't have a clear pathway that it uses every single time. It's not like you or me where we create our own recommendations. It can be very random in this. So I'm rambling a little bit there, but I want to come to kind of the conclusion of the research I've seen and the research that I think NYU doesn't really explain well, which is that sources matter that it pulls from. And as oncologists, as doctors, as physicians, we go through that and we debate this on panels of boards that put what we think are the guidelines. And we don't always just pick the most recent study because we need that to be significant enough to change what we previously recommended. So we saw that hallucinations and accuracy increase as you increase the corpus of knowledge that it pulls from, right? And this is for complex patient scenarios. And as you shrink that corpus and you make it smaller and smaller and more verified, the physicians that are practicing medicine are going to agree with the output more because it's been verified and agreed upon by other physicians that are their peers. So when we shrunk, for example, with the oncology, the corpus only the NCCN, the amount of hallucinations went down because the corpus of knowledge was smaller, and the accuracy and agreement went up because that is what other physician peers recommended. So I think that as we see more and more people try to measure things, they're consumed with power. They're consumed with, okay, I asked these 30 really complex questions and ChatGPT answered them right, but these were all found on the internet and it was trained on this data. Or I asked these questions and it was able to pull these journals from New England Journal of Medicine and we were able to cite it more right. What is the right pathway? And to me, it's safety, right? Focusing on decreasing hallucinations and focusing on only pulling things that have been verified by other peer physicians that are experts in their fields.
Yeah, I agree. And also in my mind, it also depends on the use case. So when you are trying to encompass in a single language model all the questions about a specific case, it gets lost into nuances because it may not have the evidence that it requires to make the decision making appropriately. And I think as you mentioned earlier in the Nurse Althea question is about the questions that you make that make a lot of a difference. So if I and just simply throw a whole EMR into, open evidence is going to be hard because they don't have multi-agentic components. So they're going to be able to pull different things that are important for the case. And at the same time, you throw into a large language model. If it's smart enough, like a Claude, Fable, then it's going to have enough tools to pull multiple agents and really give you the best answer possible because it's going to have dedicated orchestration that's going to give you the final answer. So I think that's probably where the field is going to evolve. But yes, it's all about the source of the specific question you're asking. And making generalizations are hard. And also, these models are changing so quickly that even the specialized models are running behind. I see now. So let's see how the field evolves. But now it just adds me to another question I have for you. Just a couple more before we wrap up. So what are the biggest opportunities that you see in AI for better optimize your practice? Is there anything else you're working on?
Yeah, so, one of the other things that I've been working on quite frequently is actually billing optimization and being able to use language models to help guide doctors to answer or creating notes that can be billed for the work that they do. And I see, again, as I talked about, I see that there are different branches in which AI can effectively evolve within medicine to be a helping hand and not a deterrent or, useless like a lot of EMRs were. One of them is within the Nurse Althea tool within teaching communication and practice. Another is within decision making. And the other branch here really is billing optimization. Billers, insurance companies design with the purpose of trying to deny care that we're trying to provide. And the rules keep changing. And I have a common saying that was said to me when I first started medicine. I was told you can either make a lot of money, you can be a good dad, or you could be a good doctor. You can pick two of those.
I
The
was
other,
also the same, and I said no. I'm ambitious. We're gonna take it
yeah.
all.
What do you mean you can't do all three? And to me, AI is the tool to allow us to be able to make the money we deserve, to be able to still have the family life that we want, and to be able to practice medicine at the fullest of our capabilities and be a good doctor. And so what our tool is doing, and I'm the chief medical officer of Scriber AI, is that we write the notes using ambient technology where it listens to the conversations, and then it runs through the billing guidelines based on their insurance and everything that they're doing, and it makes recommendations based on what the doctor said that are things you probably are going to do or did do, but maybe didn't clarify, that would allow you to bill for a higher visit. I'll give you a great example. I've never had a chest x-ray or a CT in my clinic that I didn't look at myself. But that is an increase in complexity. And how many physicians put in their note, looked at x-ray, evaluated x-ray, not x-ray report, not CT report, but looked at the images myself. You're doing things on your own that you've been trained to make you a good physician that you don't realize can also allow you to increase your revenue. And physicians deserve to be compensated for the hard work and the care that we do.
Yeah, so good point of AI to optimize all the work that we do, and AI fighting AI, right? The battle of the robots here. But yeah, that's so important for our practices and growing. So the final takeaway points that we have. So, what are you most excited about AI? And what are the takeaways you have regarding the use of AI in oncology from a perspective of a trainee and hopefully an upcoming fellow?
So I think that oncology, of all the fields in medicine, is the fastest moving, and it is the most imperative to have relationships with their patients. The way I see AI moving, not just in the level of new drugs and new trials, which are so important, right, which is impacting AI, but also in the ability to help physicians stay more up to date and to be able to be more present with their patients to give them the care that allows them to trust us. And I think that we are going to see a massive improvement in healthcare in this country as AI becomes a normal part of every oncologist's practice.
I agree. So technology and AI moves at the speed of trust, they say. And I cannot agree more. All right. So I really thank you so much for the time and the chance to talk to you. Looking forward to having more, Nurse Althea news and beyond, and for having the time to talk to me. So thank you, Connor, Dr. Yost, and look forward to seeing more from you. Once again, I'm Arturo Loaiza-Bonilla. And thank you so much for being in the part of the audience of the AI Oncology Revolution.